Um, Perfect. So let's move on to our fourth topic, which is around site of care restrictions. So this is one where, as I mentioned at the beginning, we've been seeing more and more health plans within the medical policy have a requirement. You know, maybe it's for the initial injection, maybe it's kind of for a subsequent injection, but that administration of the IV or sub-Q cannot take place at specific centers, primarily the hospital outpatient department, and that patient would need to go receive their treatment at a different center. Obviously being driven by different contracts and rates that payers have with the different settings. But like I said, I certainly talk to you guys a lot, talk to payers a lot, but we also do quite a bit of research with physicians and practice managers. So we talk to practice managers, primarily being the budget manager or even the nurse practitioner, and you know, they're a little bit, I should say a lot bit in some cases, spun up about seeing volume move to different centers or out of their institution. And I think it'd just be helpful to understand, maybe more so for Art and Fred, since Donald, I'm not sure this applies to you if everybody else is already required to go to your network, but maybe for Fred, just to start us off here, the site of care policy, is that something that your health plan has been either pushing forward or considering at this point?
Yes, and put a more intense program in place within the last 18 months, focused on around 40 drugs actually are the extent of the list at the moment. And it's gone fairly well. There's been some pushback, as you mentioned, but it hasn't been totally hard, the program. In other words, as part of the authorization process for those drugs, the preferred site is clearly indicated, and if for some reason the member of the patient can't access the drug for a clinical reason or even a strong logistical reason, then exceptions are made. So exceptions have been made, I would say, fairly liberally, although there's been a pretty good success with the program. I think the biggest issue around it is the dwindling number of non-hospital infusion sites. At least in some of the metropolitan areas where we are, the hospitals have pretty much gobbled up a lot of these practices and infusion sites and essentially made them hospital outpatient satellites. So that's an issue. But where, clearly where there are opportunities to steer the patients to lower cost administration sites, that has been the policy, and it's been fairly successful. So I think it'll continue, and we'll just have to see where things go with the hospitals. It increasingly is a thorny issue for the hospital contract negotiations, however, because it directly impacts their outpatient rates.
Right. And Fred, just any kind of trends with those 40 drugs? Are they mostly high-cost specialty drugs? Is there any particular rationale for kind of the 40 that you picked, or any characteristics of those 40?
Well, for example, I think the highest volume is the IVIG, IV immunoglobulin, which there's just a lot of different products, a lot of different options. Actually, other than that, no. I mean, it's just drugs that can safely be administered in other settings. So I think the list is fluid. It'll continue to evolve. It includes certainly some oncology products. As I said, IVIG is numero uno.
Mm-hmm. How about MS? So things like Ocrevus, Tysabri. Have you moved into MS as a category where you're doing this?
Yeah. Again, some drugs are, shall we say, softer in the enforcement than others, and so I don't have the list in front of me to give you the total inclusive comment, but yeah, I mean, there hasn't been a specific class that's been excluded just because of its class.
Okay. Got it. Okay. And you definitely see the trend kind of increasing in the future, it sounds like, where kind of expanding this list. And it does sound like there's an appeals process, as you mentioned, if there's clinical or logistical issues that could get overturned. But it sounds like this will be a policy that you'll continue to expand on.
Yeah, I think that's a fair statement. And as I said, it's kind of a fluid program. And that sort of the big issue really, though, is what happens with hospital outpatient contracts. Because if those become more friendly in terms of rates, then to some extent the issue goes away. So it gets tied up in total reimbursement for the hospital.
Yeah. Yep. Got it. Art, has your health plan discussed any kind of site of care policies? Are you doing this to date?
Well, we sort of are, but more on a passive side. We don't have anything in place that tells a physician you have to use a certain site. Our policies are more about educating physicians and patients about the options they have, what we would prefer for site of care, but we don't have anything in place, like I said, like an edit. So if a drug requires pre-certification on the medical side, part of that pre-cert would be letting the physician know where we would prefer patients to get the administration. But at the end of the day, it's a provider's choice. We don't have any incentives either for the physician or the patients to go from one site of care to the other. There's no lower copay for the member, or there's no additional reimbursement for the physician or anything like that. But, I guess down the road, could it become more of a, you have to versus we'd like you to? Probably. But I think that's something that has to change with individual providers, with their contracts that we have in place with them. Because right now, like I said, we don't have anything that we could say you have to do or you have to go to a certain site of care.
Okay, got it. And Fred, did your organization kind of consider, trying to drive this through patient cost sharing as an idea to kind of put it on the member to, if you do home health, then this will be your copay, or if you want to go to the hospital outpatient, your copay will be higher? Was that considered?
Well, that is a reality. And typically the authorization process, though, is, the patient is not doing the prior auth. It's the provider. That piece of information that if there is a provider who calls, or a patient, I should say, who calls with a question or a concern, that can clearly point it out to them. And the other thing I'd add that, access is another issue. I mean, there are some areas in our geography where we have a choice with a reasonable access point other than to go to the hospital outpatient. And then obviously you can't require them to travel 60 miles to some infusion center. So, access is, and that's particularly key with oncology products. I mean, sometimes you have no access options. So that's another modifying factor. But again, where it's possible, particularly in busier metropolitan areas and where you have the availability of alternate sites of care, the policy has been fairly effective.
Okay.
And I was going to add, Andrew, I think Fred raises a good point, and we've started, again, we can control the site of care the way we're organized, but the access issues are important. And our infusion centers, we have over 70 of them. We're open 6 or 7 days a week. We're open 12 hours a day. These are busy places because of all the cancer care and other care, IVIG, the biologics. So we've had to really focus on certainly can direct the site of care, but that we have the right access at the sites of care to make sense for patients. For the most part, focus on getting them in and getting them out in a timely manner, but also if they can go to work and do it after hours or do it early in the morning and then go to work, or even do it on a Saturday, because that makes more sense. The access issues have really crept up, and partly it's a capacity issue. We got to have 6 and 7 days a week, 12 hours a day to actually deal with the volume of patients that would not be treated if we didn't have that type of access.
Gotcha. And Donald, is there ever a way for a patient to go out of network, or is that just not possible at all? Or can there be circumstances where that's
Well, we
allowed?
would have to direct it up front, and it would be rare to go out of network. But that's why we need to make sure we have adequate access so we don't have limitations so that cancer patients, can't wait weeks to get their care. So in order to keep everybody in network, we've had to increase the access, the hours, the number of days, and that keeps us from then sending patients out. We would send patients out if we had access issues locally, but that then is a more costly way for us to provide care.
Yep. What about, so access makes sense. What about something where the patient just feels more comfortable infusing in their provider's office versus having to go to an infusion center, kind of where everybody's, side by side in beds and hooked up? They may be more anxious about that. Is that something that could the patient's concerns or the patient's sort of preference ever be rationale for kind of appeal of that decision?
So I would say yes, conceptually. I don't actually have numbers that say that happens frequently or not. And you're right. I mean, the one thing about an infusion center, except for the chairs, I mean, it actually looks kind of like a hospital ward in many ways. The chairs are a little bit different than gurneys or beds in a hospital, certainly. But yeah, I mean, I would say typically if we had a significant issue like that, it might become a home health, maybe infusion, where a patient had anxiety or other issues and we couldn't overcome it, then the provider has some opportunities to think through alternatives. The typical alternative would probably be have a nurse from a home health visit, provide the medication if we could do it safely at home, for example.